Hi, Dr. Brian Mills from Mountain View, California. Today I'd like to talk to you about non-surgical management of the anterior open bite.
So what I'd like to talk about today is the lab portion of diagnostic and treatment planning for non-surgical management of the anterior open bite. So this is a typical day in my lab, and this day we had 33 active cases. It ranges between 20 and 30 active cases at any particular time. So I don't have a lot of time to beautify my models. So today you will be seeing accurate models, but not models that have been beautified. Sometimes when I'm doing a consultation, I'll have a similar case in the lab and I'll bring a patient back to show it to them. So one day I bring a very nice German woman, Sabine, back to the lab and I'm showing her a case. She walks in and she looks around, looks at me and goes, "Brian, this is your man cave." So welcome to my man cave.
Dr. Brian Mills here from Mountain View, California. And today I have my little friend, Mr. Bones, our patient. And what we're going to talk about is the importance of condyles, but also the importance of mounting models and why. So our little patient, Mr. Bones here, has a nice condyle that allows him to open and close and function properly. But let's say he doesn't have condyles. Let's see what happens when we cut these things off. Do a little condylectomy for our friend here. Okay? So we're just going to do a little condylectomy here on one side and on the other, and just see what happens to our little friend and his function. It doesn't look so good, does it? So we'll take those condyles out. And now let's see what happens. You even have a little spring to try to hold his teeth together, but gosh darn, I can't get these teeth. I can't get them to function anymore. Wow. It's kind of like doing your dentistry without the models being mounted on an articulator, isn't it? Well, he's kind of sad here, so maybe we should give him some condyles back. Yeah, so let's do what everybody needs to. You need duct tape in your office for all these things. You never know when you're going to have to duct tape on a condyle. So, okay, we're good here now. All right, Mr. Bones, I'm going to fix you. Okay, let's get some condyles and put them back in place. Oh, that's much better. I think Mr. Bones is a happy person now. We gave him some condyles again. And look at that. So you can see, when we give Mr. Bones back some nice condyles, things work out pretty well for him. And actually function again. Kind of like having mounted models when you're trying to do your diagnosis. I think it's almost impossible to diagnose complicated cases unless you know how the entire chewing system is working. So, what are the lessons to be learned here? First, always keep a good roll of duct tape in your office. You never know when you're going to need it. So the other thing I hope you learned today is the importance of mounting your models. Because if you don't have mounted models that can replicate and simulate the chewing system and condyles like Mr. Bones has, then it's really difficult to do the proper dentistry when you're trying to reconstruct somebody's dentition and give them a nice functioning chewing system. Anyway, this is Dr. Brian Mills from Mountain View, California. Take care.
So that might seem a little dramatic or silly, but I want to emphasize the importance of moving forward. All the diagnosis and treatment planning I'll be showing you needs to be done on mounted models, or it simply won't work. So these are the questions we need to ask. We need to determine if the treatment can be done, if we can achieve bioaesthetic principles, and also the amount of intrusion. So we'll be discussing that as we move through. Here's a young woman, and she exhibits an anterior open bite, and her chief complaint is that her back teeth are breaking down, and she's already broken number 31 and requiring a crown. So again, what do we start with? First, we have to start with accurately mounted models, and what you can see is that she has a significant anterior open bite. When we look at the occlusal surfaces, we notice 31 has a crown on it. Now this is a very young woman. She's 29, has already broken a virgin tooth requiring a crown. We look at the remaining molars, and we see significant damage and wear and attrition. So as far as achieving bioaesthetic principles, we need to make sure that the joints in the socket, the same time that the front and back teeth touch, and that the front teeth have the proper overlap and overjet to provide proper anterior function. So begin with marking your models with some reference points. Scribe a line, and you can measure up to that line for each tooth. Then we'll be sectioning off the posterior teeth and evaluating the arc of closure to see if we can get anterior coupling. And what we see is that when all the posterior teeth are off, we still have an interference on number 11. So we remove that interference, and we can achieve a reasonable anterior coupling. Detail your posterior teeth, reset them in the proper position, and then simply measure up, and you can determine the amount of intrusion that's required per tooth. You can use a Bowley gauge if you prefer. You can also use a blue polyvinyl bite record. All your cusp tips have been captured properly into the index, and when you place it on your models, you can determine the accuracy of your models. For instance, on this model, this side's accurate, that side has a distortion. It's nice to know that ahead of time. Now, you'll see it seated properly on an accurate model. So this is a great adjunctive tool because it accomplishes two things. One, you can use it as an intrusion guide and take your measurement from there, but also it helps you verify the accuracy of your models. Next, we have to determine the incisal length. This is a good article you can reference regarding unworn maxillary anterior teeth and proper incisal length. So in summary, you want the maxillary centrals to be 10 to 12 millimeters in length, and you want the mandibular centrals to be 8 to 10 millimeters in length. You want approximately 2 millimeters of overjet and approximately 3 to 4 millimeters of overbite. So we go ahead and do our diagnostic wax up. And if you notice number 12, the cusp tip has been placed where I ultimately want it to be. It gives me a reference as far as orthodontic movement for that tooth. We measure, and the teeth are an acceptable length, and we can achieve a 3 millimeter overjet. Regarding tad intrusion, these are the mechanics I use. I place a buccal and a lingual tad, or temporary anchoring device, place a night-tie spring, and then activate it as a sling. With this mechanics, you have almost a pure intrusive force applied on the teeth, buccal and lingually, and it eliminates the need to have a TPA, or a transpalatal arch, wire in. The particular case we're working on, I was going to use Invisalign, and I wanted to work out the mechanics of the tad intrusion ahead of time on the models to see what it would take. So we made a mock-up Invisalign tray. I'm thinking, if I can eliminate the buccal and lingual buttons, that's potentially 8 items less that can go wrong during the case. So I placed a stainless steel wire across the embrasure area to prevent the potential of the spring opening up the interproximal contact during treatment. We have a first contact bite we create on the models, and it's a nice cross-reference that you can use in the mouth to verify the accuracy of your mounting, but also this is what you'll use to scan your occlusal views for your Invisalign. Day of placement. So we've placed the tads, and you can see I've had to section off the second molar areas. There's a little glitch in the software design of Invisalign where they can't incorporate occlusal blockouts into the design. So I had to actually add the composite, have the patient get rescanned, and a new set of trays fabricated with the composite on the teeth themselves. After a few weeks of activation, you can see we have beginning closure. And in February, we have another millimeter of closure in the next 6 weeks. We look occlusally and we can see that the tissue around the TADs is looking healthy and uninflamed. So regarding TAD placement, I let the patients know that I've had a TAD placed in my own mouth. And basically, you require some anesthetic. They place the TAD, and there's virtually no bleeding, and it's about Advil, Tylenol, so for a day. I left it in for about 6 weeks, and I can let them know that it's simply a metal stud in your mouth. It's annoying, but it's not that uncomfortable. So this is a case that was shown on the non-surgical management of PCR and DJD. So we went from an anterior open bite to a reasonable result. And here's our patient. Another patient that was featured on the PCR DJD presentation. And here's our result. And here's our patient. So what I've shown is the model work that was involved with all these patients that have been treated non-surgically for the anterior open bite. What I'd like to discuss is what I consider the hidden undiagnosed anterior open bite. So Cordray did a study, and you can see there was 596 asymptomatic and 596 symptomatic patients, and the results were that every patient had a fulcrum. And what do we know about a fulcrum? Well, when the joint is seated, typically it's on the distal tooth, a second molar, and the patient has to squeeze to get their teeth together, and it displaces the joint. When the joint's fully seated, we can see that at first contact, the patient actually has an anterior open bite. But they can squeeze their teeth together and displace the joint enough to close that. So it's very deceptive in the mouth how much of a discrepancy there is between CR and CO and what open bite might be present. So I think this just reemphasizes the importance of having diagnostic models as part of your diagnosis and treatment planning protocol, because it's almost impossible to determine the amount of vertical component contributing to the occlusal pathology in a patient without mounted models. Young man came to my office. Chief concern is that he can feel that he's hitting just on one tooth and that he has to sort of grit and squeeze his teeth to get together. And if we look, he has a first contact on a second molar, and when we have him stabilized in a first contact CR bite, you can see he has quite a significant CR-CO discrepancy resulting in an anterior open bite. When we did the preliminary diagnosis on the models, for me to get anterior coupling, I essentially had to mutilate the back teeth with negative coronoplasty to get the anterior teeth to couple properly. Now these are virgin teeth, so that is not a treatment option. So we do our model work and reset the posterior teeth with intrusion, and we can see without doing a whole lot we can get anterior coupling and approximately 2.5 millimeters of overjet. We'll have to work on that a little bit for our final result. Another patient, chief complaint, has come to my office, and in a matter of 18 months broke number 14, 15, and 18. And you can see in her mouth she has virgin teeth. Matter of fact, she broke 18 after a crown and root canal. She ended up losing 18 when it fractured a second time. We look at her functional positions, and you notice she can squeeze and get her teeth together, but she does exhibit complete dysfunction in protrusive right and left lateral. And it's not until you mount the models in CR that you can evaluate the vertical component of her occlusal pathology. We go ahead and do our diagnosis and treatment planning from a CR mounted set of models. And the nice thing about the model work is you can do different versions. So in this version, I just intruded the molars. And for me to complete the treatment, I would have to do negative coronoplasty on the bicuspids. Well, if we just intrude the bicuspids as well, it minimizes the amount of potential negative coronoplasty that will need to be done. Our progress models, and we can see that we've achieved what our preliminary diagnosis and treatment planning goals were from our first set of mounted models. And now we move on to completing the case. So here she is after orthodontic treatment, and she's had an implant placed in number 18 during that time. So we complete our final wax up and any positive or negative coronoplasty that we need to do to achieve a nice stable CR bite. So you'll notice that these aren't beautified or pretty models. Matter of fact, they look pretty crummy because I've completed all the fabrications of all my transfer matrices that I'm going to need for this case. So I don't do my photography until all my matrix fabrications are completed. It just takes damaging 1 or 2 wax ups and all the lost lab time to re-wax the case to make it that I complete all my work on the models before I start doing my photography. If you're interested in how to fabricate the matrices or doing the actual transfer of the composite onto the teeth, you can refer to these 2 YouTube videos. So we've completed our case. The composite's been added. You can see we have a fairly acceptable result. And we have a happy patient.
Started with, I needed a mouth guard. I was doing some grinding and I came in with a broken tooth. I broke them so bad that you had to do a root canal or 2 root canals, right?
And one of them broke.
And one of it, right? And then I lost that one because it was broken so bad because I broke it twice.
And we aligned your teeth.
Oh, aligned my teeth, right? Because I was still breaking them. And new crown, all the composites fixed, and the realignment. So.
And now you can wear that night guard, okay?
Yeah. The night guard's good.
And how does your bite feel now that we're all done?
Feels good.
Feels pretty good.
Yeah, it feels normal is what it is the
no
key.
No sliding like you did before, where you bite and you grind across the teeth or anything.
Nope, I'm good.
Would you do it again?
That I had to go through with all the broken teeth and all the root canals and everything. It still was not that bad. I mean, really, and the implant. But everything else was really, it went smoothly.
Just took some time.
It just took time. It took a lot of time and a lot of appointments.
Yeah. Well, you did great, Sarah.
But now they're all fixed. They're good.
And how's your bite feeling?
And the bite feels normal. I don't want any more broken teeth.
No.
Hence the night guard. Wear your night guard, people. If you show this to anybody.
I'm going to edit that. So I want to thank you for your time. I also want to thank Dental XP for allowing me to share this presentation. I hope you found it helpful and informative. And this is Dr. Brian Mills from Mountain View, California. Take care.